doctorate. He's Bachelor of Science in Pharmacology and Physiology at the University of Manchester, and a Bachelor of Medicine and a Bachelor of Surgery also at the University of Manchester. So we've got a very knowledgeable, very well respected person, and he came highly recommended to us from the Tameside group, who said he was an excellent speaker. So it gives me great pleasure to pass you over to Dr. Conal Hayton. You can then share then, Conal.
Okay, thanks for the introduction. That's the best. That's definitely the best introduction I've had. I've not had anyone list my achievements, which is nice to see. Right, let me screen share. Can't do Zoom very well. That's
Don't worry, it takes time.
Are you seeing the slides there?
We are.
Yes, thank you. Yeah.
Excellent. Okay. Well, I have to say, it was really interesting listening to the questions you're asking there, Steve, and also I'll try and talk a bit about kind of research that we're doing at Manchester and what's going on generally in the field. And I think it's a very positive. I'm actually quite positive about the way things are going in general with pulmonary fibrosis research. So I'll try and give you a flavour of what's happened and what's going on. So yeah, so you see a little bit about my background, but essentially I'm a clinical research fellow, which means what I've been doing. I qualified about 10 years ago. I've done my junior doctor training. I've come to the end of my registrar training, so I've done my 5 years of respiratory training, and instead of taking the easy route, I'd say, of going straight into a consultant job, I decided to take a tumble down the black hole, which is research. So I'm doing a PhD in pulmonary fibrosis, and as Steve said, I've been working with breath volatiles. I'll come on to that in a little bit, but so that's where I'm at the moment. I've only got about 4 weeks left of the research, then I'm moving on back into clinical for a bit, and then hopefully back to research after that. So we'll see how things go. So I think it's exciting times for research in pulmonary fibrosis. So this is the left is a picture I took at a conference in America. Now I don't think I got the perspective. If I've been a bit higher, I think you would have seen kind of thousands of people sat listening to a talk about recent research developments in interstitial lung disease. I have to say, I said this before, but I have to say that Dr. Chowdhury was in the front row of this meeting. I was obviously at the back, as you can see, but thousands of people listening. And I'd say that when you go to these conferences, interstitial lung disease is the most popular field for people attending, because there's so much happening. And this is on the right is the most recent European Respiratory Society meeting, which was obviously all over Zoom. And you can see from the views, there were 5,000 people listening to talks about recent research in pulmonary fibrosis. So there's definitely a lot of interest in the field. This is a little bit of a potted history of idiopathic pulmonary fibrosis. It's actually not that old. If you take in general, it was only first described in 1933, so less than 100 years old. And over time, things have developed, I'd say, slowly. So most of the development has been around the actual disease itself, in terms of what we call it and how we recognize it. And so actually, we've only really called idiopathic pulmonary fibrosis such, and they've only really classified these diseases formally in about 2001. So only 20 years ago. They've only really formally called this disease idiopathic pulmonary fibrosis 20 years ago. And in the 90s and 2000s, we were treating idiopathic pulmonary fibrosis very differently to how we're treating it now. So I must stress, this is just idiopathic pulmonary fibrosis and not other forms of pulmonary fibrosis at the moment. So at that time in the 90s and 2000s, we were treating the combination of prednisolone, steroids, and a drug called azathioprine, which is a drug to suppress the immune system, and another drug, NAC. We were treating it with that combination for a couple of decades, I'd say. And that was based on pretty flimsy studies, very small numbers of patients, you know, kind of patients, less than 100 patients in a study. And it suggested that it was effective at slowing lung function change. But then there was a bit of a shockwave in 2012 when there was a study called the Panther study, where they took this combination of treatment that we were using for idiopathic pulmonary fibrosis, and they compared it to a dummy, essentially. So they compared it to a dummy, and they actually found that that combination of treatments were actually having a negative effect on pulmonary fibrosis, and more people were actually dying as a result of the treatment than the dummy. So that was a really big shockwave in 2012. But so we're kind of left with a little bit of a gap here for about a couple of years where we just didn't have anything. We just had no treatment for idiopathic pulmonary fibrosis, and we kind of weren't sure what to do. Fortunately, just around the corner, we had 2 studies with these 2 drugs which we now use for idiopathic pulmonary fibrosis, pirfenidone and nintedanib. They were shown to be effective, and they were proven to be effective at slowing the rate of decline in idiopathic pulmonary fibrosis. So it's only really been, you know, the last 5 years that we've actually developed a treatment which is effective for this form of fibrosis. And if you compare that to asthma, okay, so asthma was first described 3,000 years ago, so we've got a little bit of a head start on idiopathic pulmonary fibrosis, but they've had an effective treatment for asthma in terms of inhalers for, you know, the best part of 50, 60 years, 70 years even. And they're still using the same treatments because we know they're effective. And they've managed to move on now to very sophisticated treatments for asthma in the last 5 years. So we're a little bit behind a lot of the other respiratory diseases. And why is that? Why are we so far behind? Well, the simple answer, I think, is that it's just not been funded for a long time. So this is a little bit old now, 2013, but, you know, only less than £1 million was provided by the government into pulmonary fibrosis research in 2013. So you know, that's not really going to achieve anything. So how does research get funded? Well, there's 3 main streams of funding. So one is the government, so they do, so through a couple of organisations, the MRC and the NIHR. Through these kind of organisations, they fund medical research. Charities, so we're quite fortunate in pulmonary fibrosis that we have Action for Pulmonary Fibrosis, and they've done a lot of great work, you know, over the last 5 years, improving the funding for specifically for this group of disorders, and also obviously the British Lung Foundation. Obviously, the downside there is that we're obviously then competing against COPD and asthma and that kind of thing as well. So, but we do have some really good charities which are funding, and then industry. And I think it's probably fair to say that industry provide the vast majority, probably 90% of the funding in medical research. Now that isn't just in drugs and medication, but they also do fund other studies. So the basic research as well. I mean, obviously their game is to try and make money in the long run, but we didn't see any of that funding until these new drugs came into availability about 5 years ago. So I think based on the success of the 2 drugs that we have had recently, industry are now putting quite a bit of money into pulmonary fibrosis research. So we're seeing the hundreds of millions of pounds and dollars that we weren't seeing 5 years ago. We're starting to see put into fibrosis research, I guess, to try and get the next medication which is going to be effective. And we are now starting to see, this is American news, but we are starting to see that the governments are also recognizing, certainly in America, they're recognizing the importance of research in pulmonary fibrosis, and that we need to kind of catch up. So we're starting to see a lot more investment in research. And just to highlight that, this was 5 years ago. So this was the number of studies in pulmonary fibrosis in 2015. So that is less than 100 studies worldwide in pulmonary fibrosis. And if we skip forward 5 years, we've gone 10 times. We've now got 10 times the number of active studies in pulmonary fibrosis compared to 5 years ago. So we can see the kind of jump in real terms. But we are quite significantly behind lung cancer, for example. So lung cancer has 10 times the number of active studies as pulmonary fibrosis, and as you well know, in terms of the seriousness of the condition, they're probably not too dissimilar in terms of how serious they are. So we're still a bit behind. And I've talked about what you can do, and I'm sure some of you signed a petition a couple of years ago now to try and jog the government into providing more funding, and I do feel that we are seeing some of that. Being on the research side of things and having to apply for the money, we are seeing there is more availability and there is more interest in terms of the global scheme, and I think we are starting to see that now, which is good. So I was having a think about what areas of research are the priorities when it comes to these conditions. Well, these are probably the ones I'd say. I mean, that kind of covers everything really, but particularly when it comes to idiopathic pulmonary fibrosis, but also all forms of interstitial lung disease, so rheumatoid and all other forms of pulmonary fibrosis, we're still trying to nail down the cause. And what I mean by that is the mechanism of how exactly the fibrosis occurs and why it occurs, and why does it occur in some people and not other people. So we're still trying to work that out. So that is kind of the core element that we need to nail down. And I think once we have that, we'll then get these other bits. So better treatment, that's probably the end game really. We want to try and get the best treatment. We want to try and get treatment which is more effective than what we have already, has less side effects than what we have already. And the idea would be to reverse scarring rather than just slow down scarring. We need better ways of diagnosing these conditions, because some of you may have experienced this about the difficulty in getting to a diagnosis and the delay there is in trying to get to an accurate diagnosis. And I think from my point of view, I'm most interested in trying to find better ways of monitoring this condition. We talked about this, you talked about this with the MR scan there, Steve, about kind of monitoring response to treatment. Well, we need better ways of monitoring the disease, because what we have at the moment isn't very accurate. And I guess in an ideal world, we need something where we can detect these conditions at a very early stage and do something about them at an early stage.
That was one
so I'll try and cover some of these.
Sorry, that was one of my thoughts, was if it's so sensitive, then it's going to, be able to diagnose people sooner rather than later, so that we can do more to try and prevent rather than cure.
Absolutely, absolutely. And I think with a combination of all those things, if we did pick it up early, and if we did have better treatments, and we did have something that could reverse it at the start, we could get a cure for this. And that is the goal, that is the aim with all this research, is to try and cure these conditions. So if we think about these conditions, I suppose in particular idiopathic pulmonary fibrosis, then essentially our basic understanding of why people get this condition is that they have the genes that make them genetically susceptible to get these conditions, and then they're exposed to something. So in the case of idiopathic pulmonary fibrosis, we don't really know what the exposure is. What is the thing which sets it off? It could be a dust, it could be a virus, it could be smoke. Something triggers this response, which is abnormal. I mean, for example, in rheumatoid, the exposure would be the rheumatoid, but then where does the rheumatoid come from, and things like that. So it's definitely a lot of questions, but this is our basic understanding. But in terms of the reality, the reality is this, which I don't expect you to be able to read a lot of this, but essentially what this is our understanding of fibrosis at a cellular level. So if we go down this kind of circular structure in the center, is something called an alveolus, which is basically the very bottom of your lungs, the kind of air sacs at the bottom of your lungs. And in the alveolus, and you can see below the alveolus, this kind of tube, that's the blood. So the cells within this air sac and the cells around the bloodstream, they're all involved in this process where there's lots and lots of signaling going on, and lots of inflammation and fibrosis going on. And there's lots, my main reason to put this slide up was to show you that there's lots and lots of different cells that are involved, and lots of different receptors. And this is probably just part of the process, and we're probably missing some of this information because we might find more the more research that is done. Now, the big positive, I would say, from the fact that it is so complicated, is that means, and there are so many cells and pathways involved, it means that there's lots of different places that you can use a drug to try and stop or slow the process. So all these cells and all these receptors are places where drugs could be given to try and slow this process. So there's a positive to the fact that it's so complicated. One thing I wanted to highlight, which is very much funded, some research which is very much funded by Action for Pulmonary Fibrosis, was a study looking at the genetics of idiopathic pulmonary fibrosis. And this is more or less purely funded by Action for Pulmonary Fibrosis, and through this they were able to identify some new genes which are associated with the condition. And again, the positive of identifying these genes is that they are another place where you could give a medication to try and slow this condition. So moving on slightly to diagnosis. So as I mentioned, we do have a lot of issues with getting to a correct diagnosis. And part of the reason for that is we're very much reliant on CT scans and clinical history, really, to make a diagnosis. We don't do many biopsies. Some of you may have had a lung biopsy, but we don't do them very often. We probably do, I think I probably have seen a couple of thousand patients over the last 2 years, say, and I probably referred someone for a biopsy once. You know, it's very rare that we would refer someone for a biopsy. The reason is they're too invasive. There's a lot of risk associated with it. So a lung biopsy involves an operation essentially to remove a piece of your lung. It's not the same as a camera or anything like that. And there is a risk of death with it. So there's about a 10%, up to a 10% risk of death with it. So for procedure which is just to make a diagnosis, it's in a way it's too risky. You'd only really do it in someone who is you know, very fit and young, and you really had no clue what the diagnosis was. So we don't do them very often. So what we could really do with is a different way of doing biopsies, which was safer, but still give us a result. One of the possibilities is something called cryobiopsy, which is basically a bronchoscopy technique, so a camera test, where they use a frozen probe. So the probe is super frozen, and they can attach that to the lung. So it doesn't sound sounds a little bit graphic, but attach that to the lung, and they can kind of tear off a very small piece of lung. And the benefit to that is you get a preserved section. So when you do a normal bronchoscopy, you have to kind of clamp down and tear a bit out that way, but you just kind of ruin the tissue, really. So this is a different way. They do this a lot in mainland Europe. So this is very popular in Italy and other countries, and they're a lot further on with this than we are in the UK. I think particularly here in the UK and the US, actually, we're kind of slightly behind on this, but I think that's partly to do with some skepticism amongst the doctors about the safety of it. We're still trying to work out how safe it is, but it's a potential method of getting tissue which would kind of help us get diagnosis, particularly in cases where it's really not entirely clear what the exact diagnosis is. So then moving on to treatments, so new and better treatments. So this is obviously the end. This is what we're trying to achieve, you know, with a lot of the research. Just a kind of note on development of drugs in clinical medicine. So obviously things start off in the lab with basic research, looking at receptors and trying these drugs on cells to start with. And you might start off with thousands of potential drugs, and lots of them won't work. And over the course of time, you'll whittle them down to a very select few which look like they're going to be effective. And that takes a long time. So it takes, on average, 10 to 15 years to develop a drug for a condition. And it costs about 800 million pounds to develop a new drug. Obviously, that sounds like a lot of time and money, but this will have been going on for decades, and what we're seeing now is from 5-10 years ago that we were working in the lab on. So this is always ongoing, and the money they recoup all that. The drugs companies recoup all that money when they hit a effective drug. The kind of final stage of drug development is something called a phase 3 study, where they use the drug in patients who have the condition. So that is where patients like yourself come in. It's towards the end of drug development. They don't, everything else, they start off with people who are healthy controls and have no medical problems. And when they're happy that it's safe, they move on to patients who have the condition. And this is where most of the research we do at Wiltshire is towards the end of the development stage. So we already know by this time that it works in cells and mice, and that it's safe in humans. So these phase 3 studies, they are, for the most part, something called a double-blind, randomized, placebo-controlled trial. So that's quite a mouthful, but that basically means is drugs, to make sure that they're definitely effective, what you need to do is you need to take a group of patients who have the same condition, and you give half of them the drug and half of them a dummy which looks exactly the same as the drug. That's the only way, and the double-blind bit is that the people who give you the drug don't know whether it's the drug or whether it's the dummy. That's the only way you'll be able to be certain that you won't introduce bias. So if the people who are running the trial, if they know whether you're getting the drug or the dummy, then they might kind of introduce bias in some way. So they might kind of get you to breathe a bit harder, subconsciously. So the only way you can be 100% sure, or as sure as you can be, that that you're dealing with an effective drug, is if you do this double-blind and trial where you randomly select people to get the drug or the placebo. And examples of that are these 2 drugs that we now have. So nintedanib pirfenidone for idiopathic pulmonary fibrosis. On the basis of these double-blind randomized controlled trials, we found that they were effective at slowing the rate of lung function decline in idiopathic pulmonary fibrosis. So if you do a good double-blind randomized placebo-controlled trial, the medicine will be shown to be effective and will become available. So just on the basis of those trials, we were able to access the drug. We knew the drug worked, and we were able to access the drug. Another example is probably the most recent landmark study in these conditions, which is something called the InBuild study, where they gave nintedanib, which we use for idiopathic pulmonary fibrosis, to people who had other conditions. So, for example, rheumatoid-associated fibrosis, or people who have hypersensitivity fibrosis. So they gave it to other conditions, and we found that it had the same effect as it does in idiopathic pulmonary fibrosis. So since September last year, we've had this result. We now know that nintedanib is effective for those patients as well. We are currently waiting for NICE to decide whether they'll be included basically on the NHS budget. But we know that it is effective, and it has been given a license in America by the FDA. So we would expect it to be become available to us, you know, in the next probably 12 months. So there are lots of drugs which are under development for pulmonary fibrosis. So this is probably a non-exhaustive list of the drugs which are currently undergoing these phase 3 studies. Probably the ones which look most promising is this one at the top, which I can't pronounce, which is a drug which is given intravenously. And from the early studies, it looks to do the similar job to the pirfenidone and nintedanib, but has less side effects. The other one is one of these two, I can't remember which, but I think it might be this one. Hasn't got a very fancy name at the moment. Again, this from the early studies suggests that this does a similar job to what we already have, but without the side effects that we see, which is one of our biggest problems. But there's lots of other studies ongoing around the world looking at lots of different drugs for different forms of pulmonary fibrosis. Just wanted to kind of have a little bit more of a chat about what it's like to take part. And some of you I know have taken part in research in a drugs trial with Insure. So we have a dedicated research unit which is dedicated for respiratory research. So we run trials in interstitial lung diseases, but you know, obviously asthma, COPD, and that kind of thing as well. So we have a dedicated unit which has a ward where we can deliver these phase 3 studies effectively and safely. So we're quite lucky in that respect. So what is it like being in a drugs trial? Let's say some of you will have experience. Carol's had experience of this. So it's quite I'd say labor intensive or time consuming. The first part to any of these studies is you have a screening visit, and that's well, we get your consent first to take part, and then you come for a visit where we screen you. What that means is we check you basically against a set of criteria to see whether you'd be eligible to take part in the study. Now, what I would say is that these criteria can be very strict, and the reason for that is you need to be very sure when you do these trials that you're doing it on the right people and that there isn't a risk to them. So for example, if you have a drug which is effective for the lungs, but it might not be safe that you know of for someone who has a heart problem, then you're going to have to exclude those people. And you have to be quite tight with diagnoses, and a lot of it's to do with lung function, and you have to meet certain lung function criteria. So this is probably the longest visit, I'd say, the screening visit, where we check all your medical history, you check all your medications to make sure you're not on a medication which might interact. We do your lung function, check all your CT scans and things like that. So a lot of people, maybe 50% of people who come to take part in a trial might end up not being able to take part in the trial at the screening visit. So, and that's just unfortunate, but it's kind of part and parcel of, unfortunately, of these trials. If you are included in the study, then the visits tend to be monthly often. So you come to the research facility every month and you have a review where you see a doctor who will go through if you've had any side effects from this medication that you're taking. You'll have tests done, for example, breathing tests and blood tests, and write for the questionnaires to see what your symptoms are like. And this tends to go on for 12 months. Most of these studies last for at least 12 months. Because you kind of need that length of time to see the effect that you're looking for. I'd say it is quite time consuming. Generally, a lot of these trials, they'll pay for expenses because they're run by drugs companies. So they might pay for your parking or pay for your transport and give you lunch. I don't know how appetizing the lunches are, but so there's some minor perks to it. So if you were thinking about taking part in a drugs trial, there are kind of positives and negatives to it. So on one hand, if you think about the positives, so we think about the positive first, I would say probably the biggest positive to it is more to do with helping the whole community, helping people with the condition. Because if you're taking part in a study which is placebo controlled, you have no idea whether you'll be on the placebo, and you're going to be donating, you know, your time and energy, and you might just be on the dummy the whole time. So I would, the main thing I would try and stress is that I wouldn't necessarily see it as as access to treatment as such. I would think of it more as participating in helping with the condition, essentially. I mean, I say that the second point I've written there is access to new treatment. Obviously, you know, these are new treatments. Some of the studies, if they're pretty sure that they are effective, but they just need to make sure they're safe in terms of side effects, they want to know more about side effects, then everybody gets that drug. So there are some of those studies. So you might get access to some treatment that you wouldn't have access to if you didn't take part in the trial. You get closer monitoring of your condition than you would do normally. So if you're seen every month and you're having your lung function done every month, you know, there's a better chance of knowing how your condition is going than if you were seen every 3-6 months. And I'd say, you know, for the most part, the staff are friendly, and it's a nice place to come and comfortable. Negatives. So you don't know whether you're taking whether you're going to be on a dummy or whether you're going to be on the drug. You don't know whether that drug is going to be effective. So you know, it's a trial when they're trying to work out whether it's effective. So it might be that you take part in a trial and the drug actually, it turns out to not do anything. Unfortunately, that's part and parcel, and that's why we do them. And these drugs might have side effects. We know that a lot of them do have side effects. Part of the positive, I think, coming forward is that we're now looking at drugs. Most of the drugs we're looking at now seem to be better targeted and have less side effects. But they do have side effects, and you obviously wouldn't have those side effects if you didn't take the drug. It's time consuming. You expose yourself to extra tests that you wouldn't normally have as part of normal care. So it's a bit of you know, positives and negatives, and you need to weigh these things up when you commit to a study. So this I have to say, this is slightly outdated because of COVID. This is what we were running. These were the studies we were running in interstitial lung disease prior to COVID kind of stopping everything. I say some of these, so at Wythenshawe, it's a slightly different situation in that we have a dedicated ward, the Charles Blakely ward, which is an NHS run facility. But actually across the road, and some of you may be aware of this, there's also a private research facility called the Medical Evaluations Unit, who run trials for drugs companies, but they're not, we work closely with them, but they're not NHS trials. So some of these will be these related to this private organization. But the big ones I would highlight, this one here, this Isabella study. This one is a new drug in idiopathic pulmonary fibrosis, and I think I'm pretty confident about this drug. This is a drug which is a tablet which has been shown in the early studies to, as I say, slow the rate of lung function change, similar to what we already have, but no side effects have been identified from it so far. So in the early studies, there was no extra side effects associated with it. So that'd be really useful to us given the problems we have with some of our drugs. So that's probably our most promising one. This is the Atlas study. So pirfenidone, some of you will be aware, is a drug that we use in idiopathic pulmonary fibrosis. The big problem with pirfenidone is that it does have a lot of side effects, and they're mostly upset stomach and gastrointestinal side effects. So to kind of combat that, the company have developed a nebulized form of the drug, and the hope is that it'll be as effective as the tablet form, but not have the same side effects. And we have a couple of patients who are on this study, and it does seem to be a lot better tolerated than the tablet form. What we don't know yet is how effective it is. I think there has been a little bit of news because we were using 2 doses for it. But I think they've now switched to the higher strength, because I think people who were taking the lower strength, it was not working. So that they've switched to a higher strength. The TRAIL-1 study is a study where we were using pirfenidone in rheumatoid-related pulmonary fibrosis. Unfortunately, that is one of the ones which has had to stop because of COVID. They couldn't continue that. Some of these other ones, they've been able to kind of muddle through as such, because they've set up in a way that they could continue some of the visits by telephone or kind of remotely, but a lot of them unfortunately haven't been able to continue. The other one, so the 2 currently that I believe we're still running are the Atlas study, which is the nebulized pirfenidone, and Scenic, which is another inhaled treatment to try and treat cough. So these, I think, are the 2 studies where they're recruiting patients for at the moment. The other studies, unfortunately, I think are on hold still until, but it won't be too long. I think these have recently been restarted. So I think we'll soon be restarting these other studies. And there's going to be more in the pipeline. There's always, we're getting, requests every week. Can we be a site for these new studies? So there's plenty of opportunity for people to get involved if they want to.
Tablet people up to Robert's form.
Just moving on slightly to an area which I'm quite interested in, and that's kind of monitoring these conditions. So you'll all be aware more than anyone that the way we monitor these conditions is with spirometries with lung function. And I'd be surprised if any of you are big fans of doing lung function. I'm not a big fan of it. I've done it myself. It's not particularly nice test to do. It's difficult and it's very effort dependent. So you have to put a lot of effort in to get accurate results, and it's not particularly accurate. So if I was, I'd say I don't have any lung disease. If I was doing this test, I could expect my lung function to go up and down by 5% every day. You get this variation, which is just natural part of, the test. So it's not very accurate. So I would liken it to using an old school, weight measure, when what we really need is something which is super accurate, and we get a really good idea of how the disease is progressing. So we need much more accurate ways of monitoring this condition. And there is a lot of potential markers. So you'll be aware we don't really do blood tests in idiopathic pulmonary fibrosis or other forms of fibrosis to monitor the condition. We do, if you're on medication, we take routine bloods to make sure that medication is not having an effect on your liver and things like that. But there's no marker in the blood that we could monitor and say, oh yeah, okay, so the drug is effective, or there's a marker which tells us how the disease is going. It'd be really useful to have something which would be accurate like that. There are potential ones out there, and this is just again a non-exhaustive list of all the things that have been tested. None of them have quite hit, as you can see, none of them have quite hit all the boxes. So we've not quite yet found a blood marker, for example, that can do everything that we want it to do in terms of help us make a diagnosis, tell us what will happen to the disease, and tell us how things are progressing. Potentially this top one, KL6, and we're going to be doing a study in this at Wythenshawe in the new year. Potentially this one has the most potential as a marker, but we still need more studies to kind of work it out.
Can I just ask a question there? I was reading somewhere recently about the levels of bilirubin in the blood being used as a marker.
Yeah, I've not seen that. So bilirubin is obviously a very easy test to do. We do it in it's part of it's a liver screen. I've not heard of it being used as a marker in idiopathic pulmonary fibrosis, but I have heard of other basic, simple blood markers which seem to be associated with the condition. The downside to things like that bilirubin, which can be affected by the liver, can be affected by drinking, can be affected by, can just be high anyway. The downside is if they're not specific to the condition, then you've got that kind of that error, the potential that it's something else. But to be honest, we just need to keep on doing lots and lots of studies looking at all these, and it's probably better to do, certainly look at the simple things like bilirubin and some of the blood markers, because anyone can do that straight away. So we definitely should be doing more of that. I think probably we need things which are a bit more specific to the fibrosis, but we may find that bilirubin is the thing. We just need to do more studies, I think. My area.
I'll send you the link
Sorry.
to the information I've got.
Oh yeah, please do. Please do. It's hard to keep. I was going to say it's very hard to keep up with all of these studies. Even as someone who's doing research in interstitial lung disease, I mean, it's just ridiculous how many. I mean, it's great, it's brilliant, but it's quite hard to keep up. One area. So the area that I'm focusing on in terms of my research is breath. So you might have seen some of these headlines in the news. So I'm looking at something called volatile organic compounds. Now, these are very, very small molecules that we produce, and they're present in breath. They can come from skin as well, and they may give us specific information about diseases. Now, this is quite famous. On the left here, this is quite a famous story of a lady who could smell a change in her husband 20 years or so before he developed Parkinson's disease. Now you might kind of, think that's a bit, you might kind of be a bit unsure about that, but she's come down, I think she's from Scotland, she's come down to Manchester, and she's been put through the mill basically, and she can consistently detect Parkinson's disease. And there are some people who are super sensors, who have a nose, and can smell things that other people can't smell. And what she is smelling is these things, volatile organic compounds, these very small molecules. The same thing is used here. If you look right here, you might have seen this in news as well. So there are dogs who have obviously got very good noses, who can detect coronavirus. And they're using this in Helsinki. There are dogs who can detect coronavirus because coronavirus produces these volatile organic compounds. Wouldn't surprise me if you're still a bit skeptical, but there's definite science within this. So we're looking at, so what I've been doing is we have been taking breath samples from patients with pulmonary fibrosis, and they breathe into this machine on the right here, and these steel tubes, they've got a hole in the middle, and their breath gets captured on these tubes, and we can take their breath and put it into an analyzer, and it gives us thousands and thousands of compounds which are present in their breath. And so what we've done is we've taken 80 patients with pulmonary fibrosis, and we've taken a big group of patients who don't have any lung disease, and we want to work out which compounds are present in people with pulmonary fibrosis and which are not. And what we're hoping is that one or two or a number of these compounds are specific for the disease, and that we can monitor them as time goes by, and they give us information about how the disease progresses. The positive to this is you just breathe into a mask. There's no effort required, so anyone can do it. And we think it will be more specific than the breathing tests that we do, the spirometry. So we've got a lot of hope for this. I've actually moved on to, so I've been in the university for the last few days, last few weeks. I've actually moved on to doing the same thing in cells. So I've been taking test tubes, and I've been using these tubes, and I've been taking the breath from cells. So cells are grown with a kind of a layer of air that that these volatiles can go up into, and we can extract that. And we want to see, are the molecules in people's breath the same as the molecules in the cells of pulmonary fibrosis. And if they are, they're onto a winner in terms of we've got a molecule which potentially we can monitor. So just a little bit more about research at Wythenshawe. So as well as that, we're also looking at new imaging techniques. So we talked about xenon MRI. So Dr. Chowdhury is heavily involved in a study looking at MRI scanning and another type of scanning called PET scanning in certain forms of interstitial lung disease, and she's running that with Manchester and Sheffield. Dr. Blakely is another one of our consultants, and he is heavily involved in cellular research in fibrosis. So I'm kind of I'm doing my research with him and others. And then Dr. Rivera Ortega has got a interest in the genetics of pulmonary fibrosis, and she's developing a genetic service which we're hoping that will start basically in the new year. So we'll start to be able to do genetic testing in people with pulmonary fibrosis. So, so in summary, in the not too distant future, so I'm thinking in the next, 5 years at least, probably sooner, we'll probably have better ways of making a diagnosis with cryobiopsy. We're certainly going to have better imaging with the MRI scanning, with other techniques to scan patients. Hopefully should have these blood markers, breath markers. I definitely think we'll have at least 2 new drugs, probably in the next 2 to 3 years for this condition, which would be a big step forward, particularly if they have very few side effects. And we're definitely going to be doing more genetic testing and looking into that side of things as well. The other thing, we talked about early detection. Again, you might be aware of some work that was done probably 2-3 years ago now. Got quite a lot of coverage on the news about screening for lung cancer. So in Manchester, we piloted a study where we took a CT scanner to various locations, mostly around North Manchester and East Manchester. This is outside the Etihad. So took them to supermarkets, various locations, and people came and had a CT scan as a screening technique for lung cancer. So, and that was it's been very successful at picking up lung cancer earlier and treating better. But as a result of that, we've been picking up early interstitial lung disease. So we're picking up, it's about 6% of people, which is a big proportion. It's actually more than they're picking up the lung cancer. We're picking up people who have early pulmonary fibrosis. What we need to work out is what do we do? We have this population now, and these screening programs are being run out all over the country and all over the world, really taken off. So we're going to be picking up 6% of the population who have early pulmonary fibrosis. So the big thing there, I think, is that we need to, these are possibly a group of people that we need to get involved in studies, because we need to work out from them, because they don't have the disease and they're very early in their disease course, why did they get it? What are the risk factors for them getting it? And is there anything we can do to monitor it from an early stage or treat it from an early stage? So this is something that we'll have in the next few years. So I guess in summary, I hope I've shown that there is exciting times when it comes to fibrosis research. There's a lot going on, and there is a lot of opportunity to get involved in research. That might be getting involved in a study itself, but it doesn't have to be that, because there's lots of other ways you can get involved in research. So as we talked about, fundraising, spreading awareness, the need for research, spreading awareness of the condition in general, because there's a lot of people who say don't know about this condition at all, have no understanding of it whatsoever. And actually, it is people like Keith Chegwin, and it is sometimes that when they're on the news and on kind of the early morning TV, that really does pick up. And in fact, the Coronation Street I can't say I watch I watch it. I don't have time to watch it, but obviously was a storyline about someone with pulmonary fibrosis in Coronation Street. So these are ways that awareness is being spread about the condition. The other thing that people can get involved in is focus groups. So at times, if certainly what we want to do at Wythenshawe is do more research from the Northwest. So basically, we want to turn into more of a research hub, and we'll probably ask patients like yourselves who are active in the community to take part in focus groups where we find out what do you want us to research about, and do you think these research studies that we want to do you think they'd be acceptable to do? Would you be happy to do them? That kind of thing. So there's lots of ways you can get involved, not just by taking some random drug that we give you. So so there's lots of things that can be done. It's a lot of I'd say it's very exciting to be part of. Lovely. Well, thank you for bearing with me. And if you have any questions, I'm happy to answer any questions you might have.
Yes, please. What is the difference between a lung function test and a spiral test, please? And which one's more accurate?
Spirometry is part of the lung function test. So you might see, I don't know if you've ever seen a lung function report. So sometimes, actually, I'm just going to end I was going to stop sharing so I can see everybody a bit better. I sometimes show people their lung function report, but essentially you get a very big list of numbers, and spirometry is the top section, is probably about 5 results. Spirometry tells us what your forced vital capacity is, which is basically how much air can you force out. So it gives us a rough estimate of your lung capacity. But lung function tests includes that, but also other things, something called the transfer factor. I don't know, that might be something people have mentioned to you before, but that's just another measure of how well the lungs are working. So that's a measure of how well oxygen transfers from the lungs into the blood. So so actually, if you did lung function at Wythenshawe, you might spend half an hour to an hour doing it. If you just did a spirometry test, it might take 15 minutes because you're just doing the one blows that you do. But we get different information to it and we need, they give us a little bit. So the spirometry, the forced vital capacity is essentially our main measure we use to monitor progression of the disease. So a 10% drop in that forced vital capacity is a mark that the disease is progressing. Transfer factor is useful as well. It can be influenced by other things. So we put slightly less value on the transfer factor to the forced vital capacity, but they give us a little bit of different information.
Right. Okay, thank you. Right, supplementary question. You said that doing a lung function test, that your results could vary from day to day by as much as 5%, and yet NICE stipulate a specific percent. So if I took my test today, I might not qualify for my integrity. If I took it tomorrow, I might, or vice versa. What's been said to NICE about that?
Well,
sorry.
So, no. So the reason why NICE use these fixed measures, and we obviously have we have a big problem with it. It's not, it's kind of doesn't make much sense. The reason why they use these fixed numbers is because the original studies into these drugs, they only included patients who met that criteria. So for pirfenidone and nintedanib in the original studies, you had to have a lung function within 50 to 80%. And the reason why they included those patients only is because they wanted people who had fairly significant disease. They didn't want people who had, normal lung function, because they wouldn't show as much effect. They wouldn't be able to prove as much effect. But they made a mistake in doing that, because that kind of gave NICE then the license to say, oh, well, you only did it in these patients, therefore it's only effective in this group of patients. So that's the reason why they use that criteria. At the same time, the 10% rule, while FVC does have this variation, it has been shown that if you do have a consistent 10% drop in your FVC, that has been shown to be associated with mortality. So if you do have this drop, there is a bigger risk that you die. So that is a marker of progression. And again, the studies use that as their measure to say it's effective. So they said, oh, this number of people didn't have that drop compared to the placebo. So again, NICE have said, oh well, that means it's only it's only effective if it stops a 10% drop, if you follow me. So they just very much they looked at the study and they just took it word for word, and they didn't use a bit of lateral thinking and thinking, oh well, actually, would it be effective in anyone who had this condition? And even if it slowed it by 11%, that's it could have been 20%. We know it's effective, but they are just, because it's so expensive. It's over £30,000 a year, and there's a lot of people with the condition that they're trying to manage the budget basically, and so they've just taken the evidence very literally, and it's a big shame for us really, but that's why we do need you guys to and ourselves to try and show them the error of their ways, but that's challenging. Having said that, if we have a situation where you're taking the medication and it does drop by 10%, then I would use my discretion and say, well, we'll do it again next week, or we'll do it again in a 3 months time, because we know there's this variation. So we have got that license to, we just kind of throw it back at them a little bit and say, well, there was something wrong that day, we're going to repeat it again. Obviously, if we consistently show when you do these tests that it is dropping, then I guess you'd have to say, probably isn't working for you. Maybe we have to use the other drug or whatever. So that's how we get around it. If you say you did, and the other problem is you just come to see us say every 3 months, you're just going to have 3 months, 6 months, 12. You're only going to have 4 results. So you might have just had a bad day those 4 times. So we use our discretion, and there isn't that many people who have to stop the drug because of that problem, because of the progression. It's quite a small number that we have to use that rule for. Sorry, Carol, you're
yeah, just a couple of things really. I mean, I know you talked about early diagnosis and the CT scan. I mean, I'm coming at it from a rheumatoid perspective, and it's more of a comment really, that I battled to get it recognised. I knew there was something wrong because I had this silly persistent. I knew there was something wrong. I've never smoked, and I know my body. And everybody kept saying, your X-ray's all right, your lungs are clear, and I kept telling people. And had I not had contacts that I did have, and I spoke to some of my friends that were respiratory nurses, and I would have gone on for ages because I needed the CT scan. And if that's routinely what they do, I mean, I know they do it with other drugs, don't they? Like amiodarone, just do your routine 12 monthly X-ray. Well, it didn't show anything. So it's not just the public that don't know enough about the condition. It's about our health professionals as well. And that's more of a comment, really. I mean, my GP, it's been a learning curve for him, I think. And he's drawn the short straw because he's got me, I'm afraid. But I wondered about, you talked about funding, but how does our funding for the lung, there were categories, weren't there, for government funding, the Lung Association and the pharmaceuticals and things. How does that compare, for example, with cardiovascular research?
So just about your comment about doctors, I totally agree with that. By the way, it's there's definitely poor understanding of this group of conditions, and also quite a negative feelings about this group of conditions among healthcare professionals, unless you work specifically with interstitial lung disease. Even actually within respiratory doctors, you know, they haven't, you know, they feel there's nothing you can do, and they have very negative opinions of the condition. But actually, you know, I hope I've shown that there is a lot that's going on. There is a lot you can do, and people are still skeptical about the drugs that we use. But you know, there's a lot of education that we need to do, you know, as people who work, you know, with this group of disease, more proactive, I think, at trying to educate people. In terms of how does it compare to cardiac disease? Well, I definitely think that we're much, you know, the funding is nowhere near what there is in cardiac disease. Difficult to say. I mean, I think part of the reason is understanding about this group of, I'd say, it's not well recognized group of disorders. You know, even COPD, which is probably better recognized, there's definitely much less funding in that compared to, say, heart disease. Whether it's partly the work of the British Heart Foundation, and you know, obviously they've been very active for a very long time. Whether they've maybe been a bit more successful, or maybe the connotations with smoking. I mean, smoking is obviously, you know, involved in you know, heart disease, but you know, I guess, you know, you think of, you know, lung disease, and you think of, you know, lung cancer and smoking and emphysema and smoking, but you know that's not the case in idiopathic pulmonary fibrosis, and even with COPD and things like that, it's not, you know, that shouldn't be the case. It shouldn't be thought of in a negative light. But basically, the simple answer is we are much further down the list compared to those conditions. I do think that cancer has been the focus for a long time of funding by the government and universities. So and that's probably just a legacy of the 90s, and you know, the fact that, you know, we didn't have very good treatments for cancer for a long time. A lot of people were dying of cancer, but things have dramatically changed. But that's a result of the funding. But I do think that people are recognizing that there's this whole group of other diseases which are equally as important and need funding. So we're definitely seeing a lot more. It's definitely easier for me, I'd say, in terms of trying, if I need to get money for a study, it's definitely easier for me than it would have been 5 years ago. There would have been no chance to do what I'm doing now.
And can I just ask a general question quickly? I'm sorry, I don't want to take more than my share of time, but I did go swimming a lot. I was swimming a lot. I was going at least three times a week. I built it up. My exercise, I was really pleased with what I was doing. I think that's where I contracted the coronavirus, in the changing rooms. And I think, well, I think for one, my husband's nervous of me going back, but I want to go back. I can't walk very far because of my joints, and I struggle with that. But the swimming, I could swim forever.
Yeah.
And I'm nervous. Or should I just wait for the vaccine?
I think it's difficult, really, because you kind of assume. I think if you think logically about it, if you've had the virus, you just expect to be immune to it. This is the kind of unknown slightly. So you've had the virus, so you should have produced the antibodies which is basically what the vaccine is designed to do, is for you to produce the antibodies, so that if you were to come into contact again. So in theory, because you've had it, you'd have thought you would then be immune to it. But at the moment, we don't know that. We don't know whether having it gives you the immunity to it. So, as I said at the start, I had it in April time. I then had my antibodies checked in monthly, and I was positive, I had antibodies, but then I got to August time and the antibodies were no longer there. Now, I don't know what that means. I don't know whether that means I am immune. I don't know if, you know, I was immune and don't. So these are the questions we don't really know the answer to. I think I mean, I've been exposed to a lot of people with coronavirus, I'd say, just from the job I do, and I've not had any further symptoms. And in fact, my wife had it then a couple of months later. I didn't get any symptoms. So the short answer to you, Carol, is I don't know the answer.
So I'll wait for the vaccine.
Yeah, my personal opinion is that I would be surprised if you got it twice. I don't know anyone. I don't really know anyone who has, and if they have got it twice, you wonder about their immunity. I don't know, but there's lots of questions we don't know the answer to, essentially.
Thank you.
Is IPF hereditary, please? Listen.
Yes and no. So there are certain conditions which have a very clear genetic, that can get passed on there's a clear genetics to it. So for example, cystic fibrosis, that's a genetic disorder which you only get if you get 2 copies of the gene which, code for it. In IPF, there are definite genes which are associated with the condition. But that doesn't necessarily mean you're going to get the condition. What it means is you are more likely to get the condition than someone else who doesn't have those genes. And I think there is also lots of people who don't have those genes. So I guess the answer is yes, it is a genetic. There's genetics in it. So you are genetically susceptible. But some people, it just happens by itself without the genetics, and some people it won't. You won't pass it on if you follow me. It's a bit more complicated than just being hereditary. But what we do know is that, and there was an interesting study looking at the risks of getting pulmonary fibrosis. So what they looked at was, because when you think about idiopathic pulmonary fibrosis, I personally think of, it's very common in the Northwest. You think about industry, you think about, dust and, smoke, pollution, those kinds of things. So what they did a study where they looked at risk factors like people who are exposed to asbestos, people who are exposed to various dusts, metal, smoking, and they found that if you had a relative who had pulmonary fibrosis, that trumped everything else. It was the strongest. It was the strongest risk factor for getting pulmonary fibrosis. Everything else maybe increased your risk. So asbestos increased your risk by about 2 times. Having a relative who has pulmonary fibrosis increased it by 12 times. So there's definitely a big genetic component to it. I think we're only really appreciating it now, that actually the genetics is a lot more important than we thought previously. We thought mostly it was exposure to something. You're exposed to something and you get it. But probably what it is you have those genes and then something happens, something triggers it.
Thank you.
Any more questions?
These are good questions. Hard questions to answer.
Putting you through your paces. Well, can I say thank you ever so much on behalf of the group. It's been really interesting. And I forgot to mention in your introduction that you were one of the recipients of the Action for Pulmonary Fibrosis fellowships. Is that correct?
Yep. Yeah.
In 1980.
That's right. Yeah.
Yeah.
That's right.
Yeah. So I had already put you forward for doing one of the Action for Pulmonary Fibrosis webinars.
Can
so
I
you may get called upon.
Yeah, absolutely. No, it's been, to be honest, I really enjoy doing these. Oh, sorry, Sophie, you're going to ask a question.
Yeah, I had a lung scar previously, and in last September I had a COVID. I recovered from COVID, but it left a more scar on my lungs. So gradually, will it go away when the time goes by?
Again, that is a little bit of an unknown. That is a bit of an unknown. So this is one of the big concerns we have about COVID. people who already have pulmonary fibrosis, will it get worse as a result of getting COVID? I think there is some evidence that it might leave you with a bit more impairment. But again, we don't really know is the bottom line. The other concern we have is that because of lots and lots of people getting COVID, are we going to see lots and lots more people with pulmonary fibrosis? And again, we don't really know that. From my own personal experience, I've probably seen about 100 people with COVID. Of the people with pulmonary fibrosis who got COVID, the vast majority fully recovered back to where they were before they had the COVID. I think from some of the studies, it is more risky. It's definitely more risky to get COVID if you have pulmonary fibrosis. I think that there is an increased risk of you coming to harm if you have pulmonary fibrosis. But the majority of the patients that I saw seem to recover back to baseline. And I'd say I think probably 1 or 2 patients who were healthy before they got COVID, of about 100, I think probably 2 have developed some changes similar to fibrosis. So I guess, yeah, we have to read of that, read of that as you will, but definitely it's been a big worry for us, the impact of COVID. But I think probably it's definitely less of a worry now than it was at the start. I think we're probably seeing less problems from it in terms of people with fibrosis than we were expecting to. It definitely is. I can't deny it's definitely a concern, and I think part of the reason why we've been lucky is because of all the shielding you've done. Patients with pulmonary fibrosis have done. I mean, that's the reason why we're not seeing the problems that we were expecting to see. I know obviously people are getting COVID still, but I think the impact of it has been all what you guys have done in terms of the shielding. That's had a massive impact on the negative impact that could have happened with it.
Can I just ask if, from what you've saying, we know a number of people who've had COVID who've got IPF, and like you say, they've only had it mild symptoms. So is there something you think that's going on in their immune system with the IPF that's giving them resistance to the COVID? So they're only getting mild symptoms.
I don't think so. I think to be honest, I was really shocked. Obviously, I've been doing research for the last couple of years, and then coming back to look after patients with COVID, I was really shocked at what I was seeing in terms of seeing people who were young and healthy, no medical problems whatsoever, getting really, really severe disease without really, it can be completely random. So, of the patients we were having on ICU, they were really young, the patients in their 30s and 40s, and, normally we wouldn't be seeing that at all. So it affected people really differently. Some people very severely without really a reason why. I think we're struggling personally. I think we're struggling to work out, why some people are getting it. It must be, in my opinion, it must be to do with the dose they're getting, the viral load. It must be because, there isn't anything else which is coming out. And we were seeing patients who, like family groups, all being hospitalized with severe illness. And that would include, I remember seeing a family of, a husband and wife and a stepdaughter. So obviously no genetic link and age differences, and they're all hospitalized with severe COVID. You can only think that is to do with their, the viral load that they received, or the exposure they got, rather than their bodies or the genetics. Obviously, we have seen the kind of the ethnic risk factors. That's definitely we definitely have seen that, but everything else I cannot put my finger on at all. And I think personally the reason why patients with IPF have done better than I expected is because they've been very careful and shielded, for a long period of time. and maybe the exposure they've had, they may be starting to get those exposures now, but maybe the viral load has dropped now. We're dealing with kind of lower level COVID than we were at the start, when we were seeing lots and lots of people with severe illness.
So in that case, the health service should be ploughing more money into people like us, because we've saved them an awful lot of money by shielding.
Exactly. Yeah, absolutely. You definitely, you know, hats off. Basically, you definitely done what you did your duty, other than, you know, compared to some high-profile individuals who maybe have followed the rules as closely. You know, I think you've done really amazingly, really. So, and it's been worth it. I would say, judging from what we were seeing, and it was quite scary. Seeing severe cases, it's unlike anything we've ever seen before. So I think it's done really well.
Going back to the making awareness, I know that Action for Pulmonary Fibrosis have made a video that's been trialled within GP surgeries for the GPs themselves. So that's now going to be rolled out throughout the country. So there should be more awareness with the GPs. Yeah.
Absolutely.
I know.
Yeah. I think it goes back to
my GP is a GP trainer.
I think.
And as I passed on the information, he was most grateful, because he was able to pass that on to his other students.
Absolutely. I think part of the problem with doctors is that we maybe don't keep up with everything as well as we should do. And I suppose if you think about it, really, things have changed so much in terms of pulmonary fibrosis in the last 5 years that, you know, a lot of people's opinions of it are from medical school, which might have been, you know, 20 years ago, and they might still think us treat it completely differently. So people don't necessarily keep up, but it's hard to, you know, especially if you're a GP, you know, when you've got everything, you know, there's lots of other conditions, and I guess that's where we, as specialists, need to take more responsibility to educate the, people. So, but we're growing as a department, and we're probably able to do that a bit better moving forward.
Excellent.
Well, I'm very grateful that we actually live in this area, because if we were living, I don't know, in South Wales or Cornwall, I think we'd have a huge problem at getting any sort of treatment for the condition, because they don't have the hospital situation that we have here in the Northwest. So
that's right. Yeah, no, absolutely. And there's definitely inequality, kind of health inequality within the UK. I mean, my parents live in Northern Ireland, and it's kind of completely backwards in terms of, the options there are there, and you can't do much about it, to be honest. So it's definite health inequality, postcode lottery, you might say. But there's lots of good places that
we've one of the group leaders from County Antrim, and he was saying that a lot of their members have got to travel 2.5 hours to get to a meeting.
Yeah,
but they still do it, which is great. I know I recently contacted Sarcoidosis UK because I was looking, and from Bolton, the nearest one is up in Leeds, and then the next nearest one to us is Burton-on-Trent. So they're very few and far between. So I've offered that we will take sarcoid patients into our group, so at least they've got that gap between the two.
Yeah.
And we've suggested that to other group leaders as well, to try and improve the number of support groups. For all the
well, I mean, this is the way forward.
Yeah.
I mean, there's this kind of Zoom and remote everything. Remote work is definitely the way forward. And I think some some things, you know, we're in terms of healthcare are going to be completely different now to how they were, you know, before COVID. It has changed a lot. So particularly with regards to outpatient appointments and that kind of thing, I don't know how you found it, but I think for some situations it probably is better to do it, you know, remotely, you know, or there are some benefits to doing it remotely. Obviously, some things are better in face-to-face, and we definitely need to see patients face-to-face. But there are some benefits to this kind of remote kind of working and consultation and things like that. So I don't know how you feel
I
about
totally agree with that, because for getting the range of speakers, you can go farther afield, and you're not having to worry about transport for them. You know.
Yeah.
So it's very interesting. I'm very much aware of the time, that it's now 4 minutes past 4. So again, I thank you ever so much. It's been really interesting, and I certainly keep in contact with you regarding the research. And once we get face to face, you're more than welcome to come and join the group. It'd be nice to meet in person rather than through technology.
Absolutely.
Yeah.
No, well, thanks. It's really nice to see you all, and yeah, it was a really good question. I did a couple of talks this morning to some respiratory doctors. 0 questions. No questions.
Because they know it all.
So at least, you know, I mean, I don't know, I hope not. But yeah, at least some interested audience, and it's really good to speak to you. And yeah, love to do some more. And I hope you'll be enthusiastic about the future and excited about the future in terms of what's, you know,
I'll just give a plug.
What research is bringing.
Yeah.
Can I just give a plug?
Sorry, go on, David.
Sorry, can I just give a plug for the Charles Blakely Ward, which comes under your remit? I volunteered to take part in a nebulizer trial for cough and IPF, and at my interview screening, I was rejected due to being on Ramipril. However, I qualified for the Canal Trust, and the service and the helpfulness and the understanding between the staff there and myself. You know, yes, I was there to help, but it was.
They made you very welcome. You felt part of it. Like yourself, when you're giving information, it's at a certain level which we can understand. And if we didn't understand, we could ask. And there wasn't a daft question. And they were just smashing. Like, you know, like today, we're listening. A lot of it, no, it's going to be over here. But the majority of it you can understand, because it's relating to something which you are incredibly involved with. But the ward people were absolutely smashing. We'd get there and they'd offer us coffee or tea.
Not if you've been fasting.
No, he would get breakfast afterwards. But even I got offered, you know, we'd like some no, I'd eaten. But and that makes it worthwhile, because Wythenshawe isn't the easiest place to get to. Parking can be a real bind. But no, it was a nice experience. Yeah.
Excellent. I'll pass that on.
Good.
But thank you for your time today too. That was smashing.
No, I really enjoyed it.
Can I just ask one question? We've managed to get a satellite branch from Wythenshawe being set up at Bolton in the early new year, so that people don't have to travel to Wythenshawe. Is that possible with yourselves when you're doing monitoring of patients through trials? Could that be done at a similar thing in Bolton, or would it have to be, or is it?
It can be. It can be. It kind of requires a little bit of infrastructure. So because some of these trials are quite time consuming, you need to have like a dedicated, at least a nurse, a research nurse who take ownership of it, and equipment and that kind of thing. It can be done. So I've worked with Blackpool, for example. I've worked and they do that and have a 1 or 2 research nurses, and they kind of call them pick sites, where there's a like a central place like Wythenshawe, and they're kind of they tag onto that. So yeah, potentially it would also need one of the doctors to kind of take ownership of it. But I know Gareth, so Gareth Hughes, who's kind of taking. So he may be interested in doing that.
I'll have a word with him, because he's taken over ostensibly lead on ILD, so
Yes.
He's very keen. Yeah.
Absolutely. Yeah. So we know we work together quite a lot. So yeah, that if he's interested, it can be done. So
Right.
I mean, it kind of depends on the studies, but yeah.
Yeah. Well, we've got it from the horse's mouth, as it were, to say, and I'll take it back
Any
to the
study that I
hospital.
do,
We'll start campaigning.
I'll
You with me on that one, Carol?
Come in, get my banner.
The banners. Excellent, excellent. Okay, I think this is the longest meeting that we've gone on without having a cup of tea or anything.
Been really good.
I thank you most sincerely for your help and your support. And it's also nice to know that we've got somebody we can contact should we need advice.
Absolutely.
Yeah.
Yeah, absolutely. Yeah, any interest or questions about research, I'm happy for you to contact me. Email. You've got my Steve's got my email thing. So
yeah,
if you've got any questions,
yeah,
happy to answer those.
Please pass on our best wishes to John Blakely, because it was 12 months ago he was the speaker when Jean-Michel was over from Paris, because he was keen to get his research project going. Yes.
Going. Absolutely. Yeah. Yeah.
Okay then. Thank you ever so much.
No problem. Good to see you all.
Likewise.
Thank
Enjoy it.
you.
Thank you
Thanks very much.
Thank you. Bye.
Bye-bye.
Bye.
Everybody enjoy that?
Yeah,
Yes,
once
yeah,
again,
yeah.
excellent.
Yes.
Very good.
Yeah.
We're very fortunate that we've got places like Bolton and Wythenshawe in the northwest. Yeah, I was reading about one of the radiologists at Bolton, and he's doing an awful lot of research into artificial intelligence in diagnosing lung conditions. So hopefully I'll contact him in the next few weeks and get him to come and speak to us in the new year. So
You're not looking for a brain transplant for me, are you?
I don't think we want to change it, David. No, not at this late stage. Yeah. Yeah.
Will you excuse me?
Yeah, come on.
Going to have to go, but that's been brilliant. And anything I can do, just give me a call.
I will indeed.
Thanks, Carol.
Thank you very much indeed.
Please
Take
do.
care.
Bye for now.
See you again, Carol.
Bye.
See ya.
Are we having another meeting between now and Christmas?
So a Christmas party, isn't it?
Is our Christmas party? Yeah.
I can